Welcome and thank you for standing by. At this time, all participants are in a listen-only mode until the question and answer session of today's call. At that time, if you would like to ask a question, please press star 1. Today's conference is being recorded. If you have any objections, please disconnect at this time. I would now like to turn the meeting over to Ms. Michelle Carnes. You may begin.
Thank you. Hello and welcome to our webinar for today, Lessons Learned from the White Mountain Apache Surveillance System. I'm Michelle Carnes. I'm a project officer in the Garrett Lee Smith program for the State and Tribal Grant here at SAMHSA, and I want to thank you for coming to join us for this exciting webinar. This is something that we get a lot of questions about, the White Mountain Apache Surveillance System. So today we're going to have a presentation from our White Mountain Apache and Johns Hopkins colleagues, and then at the end we're going to have about a half an hour for question and answers from you. So today we're going to hear about the history and the development of their surveillance system, the data collection and follow-up that they use, the knowledge gained from the data that they collect, and then the implications for suicide prevention. They're going to talk about the strengths and challenges of this mandated surveillance system in their community and give you some practical information about feasibility and implementation issues. You'll have time to ask questions about how to gain support for local data collection and possibly surveillance in your own communities. And so before I turn it over to them, I'm going to give you a little bit of background on who you're going to be hearing from. Our first speaker is Novalene Goklish, and she's a senior research program coordinator at the Johns Hopkins Center for American Indian Health in White River, Arizona, and she directs the suicide prevention efforts of her tribe, the White Mountain Apache. The second speaker will be Rosemarie, and she is the research program assistant for Johns Hopkins. She's been there 7 years. She's the data specialist, and she works on the data for their surveillance system, including doing cleaning and entry, so she's intimately familiar with it. And she's also a facilitator for the survivors of suicide at the White Mountain Apache. And then finally, our third speaker will be Mary Cwik. She's an assistant scientist at the Center for American Indian Health at Johns Hopkins, and she's working on 3 initiatives addressing youth suicide prevention through community-based participatory research with the White Mountain Apache. And so Novalene's going to kick us off today with our webinar.
So I have a question before we get started. How do I turn?
Sure. What's your question?
How do I go to the next slide?
Let me see if I can, let me see if it'll allow me to advance it. Hold on. My computer's catching up with the live meeting. Hold on just a moment. We'll have visual here in just a second. Okay, here we go. Does that look right?
Yes.
Are you able to advance it?
No.
Okay, let me see if I am. Let me see if it'll work for me.
There you go. Thank you.
Yeah, sure.
So will you be the one controlling the slides for us then?
It looks like it.
That works.
Okay.
So good afternoon. Thank you so much for your time and joining the webinar. So we're going to give you a little bit of the demographics for the White Mountain Apache tribe. Did you go? Can you go back to the other slide, Michelle? So the White Mountain Apache tribe is located in northeastern Arizona. We have more than 15,500 enrolled tribal members. We have about 15,000 that reside on the reservation, but not everybody is a tribal member. The Fort Apache Indian Reservation is 1.6 million acres. We're geographically isolated. It takes us about 4 hours to get to Phoenix. It's a 4-hour drive. And then we have a spectrum of traditional and mainstream cultures. We're governed by the White Mountain Apache Tribal Council, which is 11 delegates. We have over a 30-year relationship with the Johns Hopkins University Center for American Indian Health, and the founder for the Center for American Indian Health, Dr. Mathuram Santosham, still works for the center and has a strong relationship with the White Mountain Apache tribe. We work on a variety of different programs through Johns Hopkins University in partnership with the White Mountain Apache tribe and the Indian Health Service, which is the infectious disease programs, our behavioral and mental health programs, and our training programs that we have that take place throughout the reservation. Next slide, please. When we talk about suicide on the reservation, in the early, prior to 1950, we had very low suicide rates on our reservation. Once we hit the 90s, we saw a big spike in youth suicides, death by youth suicides on the reservation. And it continued where we had a fluctuation between 9, 10, and 11 deaths in the years of 1990 to 93. All the deaths were by suicide, and about 80% of the deaths were by hanging. And then in 2001 is when we had another big spike with the death by suicides on the reservation. And so we'll go over what happened in between that duration. So if you go to the next slide. So the history of the tribe's response is when the spikes first occurred in 1990, the tribe worked with the behavioral health program and the police department to figure out what type of support they needed to get through this. And so the tribe worked on seeking guidance and support in 1992 by reaching out to Johns Hopkins University and asking them what made the most sense on how to move forward in understanding what was going on the reservation. And so they held a meeting with all of the leaders on the reservation. The meeting was held in Baltimore, and they wanted the community members and the tribal members that were coming to the meeting to actually focus specifically on the intervention and prevention that was going to take place within the tribe. And so they did go and meet with the leaders to figure out what needed to happen. And so they went ahead and met in Baltimore. They went over what made the most sense. So through interviews that were conducted in 92 and 93 allowed for the tribe to apply for some funding to implement a support group in the community that would be conducted by our elders. And that's where the implementation of the Ghostbusters takes place. That's not what the original name of the group was. It's where they were a suicide prevention group, and then the community members just called them the Ghostbusters. So they're the ones that like to come up with all these names for the different programs. Sometimes they rename everything from us, which is a good thing because then it takes ownership by the tribal members. And so the Ghostbusters was implemented in 93 to 98. During that time, our elders would go with the police officers to respond to any of the calls that came in for individuals that were struggling with suicide. And so the elders would go and spend time with them and talk with them and redirect them and guide them and offer support so that it gave them what they needed to be able to focus on, resolving those issues. And then in 2001, we had a tribal mandate put in place where the tribe passed a resolution mandating the first responders and specific departments on reporting suicidal behaviors to a centralized location. And then in 2004 to present is when the actual suicide surveillance system was implemented. Next slide, please. seeking guidance and support in 1992. So what they did is they held meetings in the different communities to have a better understanding of what community members were going through, the struggles that they were having, and why individuals were choosing suicide. And so once they did those meetings, they realized that it was really important to gather as much information because it was going to help shape whatever program they were going to try to implement. And then the tribal members and the tribal councils, tribal members went to the tribal council meeting requesting for some type of action from the tribe, asking them to do something, and that they were, it was the deaths that we were having, it was ridiculous, and that the tribe needed to have some type of action in place, and that's where they started working on implementing the Ghostbusters. So they had a variety of meetings, as you can see. The Tribal Council met with the health authorities, and the Tribal Council and the health authority met with Johns Hopkins to request for their assistance in what they can do, and then community assessments and surveys were conducted. They were actual in-depth interviews that were conducted with community members that lost family members to suicide on, why, to give them an understanding of what was happening, what were the struggles they were dealing with, and how they could move forward. And also the community wanted to know, how they were supposed to deal with all this loss, especially because they were youth that were dying by suicide. And so the community was hurting and they were suffering. And so the tribe was trying to respond to address the needs by reaching out to professionals that could help guide the tribe in the right direction on what needed to take place. And funding was given for 5 years to allow the Ghostbusters to go into the homes and talk to family members. And the death by suicide decreased during that time, and it allowed us to focus on what needed to happen, and that the elders were doing a really good job by going out and meeting with community members. Next slide, please. When the tribe applied for the funding through the federal government to implement the Ghostbusters, the tribe worked with the police department, and the Ghostbusters were housed through the police department because they were the first responders, and it made the most sense to utilize that information that they received from the interviews that were established with the assessments and surveys on how to work with the community. So the elders went through a little bit of training that allowed them, to be able to address some of the questions or concerns that community members might have that they were dealing with, that were struggling with suicide. And the Ghostbusters consisted only of elders, so elderly community members that were willing to work all hours, odd hours. They were up in the middle of the night. They would spend hours on end with community members. And so this allowed the Ghostbusters to work a schedule that's very unique. And so they worked with police officers, and they were on call, and so they knew when the police officers would be coming to pick them up and be taking them to someone's house. And so the elders resided in the different parts of the reservation so that the whole reservation was covered. And so they would go and spend time with community members, and then they would also go with them to the behavioral health services if needed to offer support when that person was trying to get counseling or some type of professional help. Next slide, please. The tribal mandate that took place in 2001 was formed by the Tribal Council formed the Suicide Task Force. Through the Suicide Task Force, the tribe also mandated that the reporting system be implemented. And so the reporting system back then was just a paper and pencil where they filled out a form and then they would write it down in a binder, and they kept all of that information. And so whenever somebody had time that was a part of the high-risk task force or the suicide task force, they would go out and try to do follow-up visits. But the follow-up visits were very limited because there was no resources that supported that effort. And so the tribe worked with the high-risk or the suicide task force members to try to move forward on how to implement this. And also the tribe wanted to figure out what type of forces they needed in order to do this, and they realized that they really needed to receive funding that supported a manpower that would go out and do follow-up visits. From the follow-up visits, they would also refer to additional agencies, and it wasn't happening. And so the tribe gave the Suicide Task Force permission to apply for funding. So the Suicide Task Force received funding for 1 year to do follow-up visits. through the follow-up visits, they found that it was very effective, that community members really liked the outreach that was taking place, and that they felt that they were receiving support from community members, and it showed that they cared. And so by implementing that, and they wanted to be able to do that a little bit more, so the Tribal Council wanted that to continue, and that's where they reached out to Johns Hopkins University. Next slide, please. And so the tribe reached out to Johns Hopkins to help maintain the surveillance system, and also to upgrade it so that it was now going to be a computerized surveillance system. And so Johns Hopkins partnered with the tribe, and they launched a new project called Celebrating Life. And through that, they updated the registry, that made it a web-based. They also hired individuals to receive training so that they could conduct the follow-up visits that we received referrals on. So all reported suicidal behaviors were now being streamlined through a centralized location, which is the Celebrating Life program. And through the Celebrating Life program, staff were going out and doing follow-up visits with community members and referring them to agencies or services that they were requesting. The Celebrating Life program also is a program designed for youth who make an actual suicide attempt. And so during that time, we were also working with the youth who made an actual suicide attempt to collect data to find out how we could put together a curriculum that the youth would then benefit from. We also did case management and aid referrals off the reservation to other services if they didn't feel like they wanted to receive services here. We also referred to churches, to spiritual leaders to help us with them, our medicine men and women, so we would refer to them as well, and then we've referred to the local behavioral health programs. 2006, Johns Hopkins partnership expanded with the Garrett Lee Smith funding, design and piloting of prevention interventions, and we had 3 tiers: universal, targeted, and selected. And at this time, I'm going to turn the slide over to Rosemarie Suttle.
Okay, on our surveillance system, we use a yellow intake form, which we collect people information on people that have attempted suicide, that have self-interest behavior, that have had ideations, and had binge drinking. So we collect information from all tribal departments, from health service agencies, from schools, from church, and individuals. So the next slide, please. Our intake form looks like, go ahead and go to the next. Our intake form looks like this, where it has the name, the gender, the tribal affiliations, their marital status, their education, and it goes into details on home location. If they can't give us their home location, then we go. We have access to the RPMS at the hospital, so we go down to the hospital and get that information. So on the next, go ahead and go to. This is our pink form. This is our follow-up form. This is what we use when we go out and when we collect the information from the person that we're getting the yellow form on. We go out there, we find the person, and when we do the follow-up, we ask them a bunch of questions. We verify the surveillance data is where we ask them, we got a form on you for suicide attempt or ideations or self-interest behavior. And we go through like 9 pages of asking them all these questions, and then we also ask them if they've seen somebody from behavioral health, or if they're getting services anywhere, and if they would like us to help them get services at behavioral health, or to go have contact with a church or someone they would like to talk to. So this is what we do. Next slide, please. I will turn it over to Mary now.
Great. So hopefully everyone can hear me okay. So I'm going to shift gears and talk a little bit about some of the information that's resulted from the surveillance system. So here you can see that this slide really has allowed the tribe to have rates specific to their community. So you can see here the U.S. all races rate, the American Indian, Alaskan Native rate, and then the rate calculated for the White Mountain Apache tribe. And you can see the time frame here is from 2001 to 2006. And we have the total age, all ages on the first row, and then in the second row we have for youth specifically. And so you can see here that from the time that we calculated the rates, the Apache rates were 40 per 100,000, so that's 4 times the U.S. all races rate. And among young people during that time frame, the rate was almost 130 per 100,000. So that was 13 times the U.S. rate. And so having this information had really helped the tribe in seeking other kind of resources and funding to be able to show the significance of the problem on their reservation. In addition, just for your information, we're in the process of updating the rates now, so calculating the rates from 2007 through 2012, so for another time period there. So we'll have those updated rates soon. Next slide, please. Okay, so some of the other things that the surveillance data has allowed us to look at, this slide shows the methods that were used in different populations. So when this data was calculated, you can see here that in the general U.S. population at that time, that firearms are one of the most significant methods of suicide death. And you can see here that on the Apache reservation by the black bar, that at that time hanging was the most significant method sort of used. So the tribe was able to collect data that show that their trends on their reservation might not always mirror the national trends, and they were able to kind of see what that is and could have implications for suicide prevention here. So we know that stricter firearm laws and means restrictions are some methods that are proposed, called means restrictions sort of in the general U.S. to sort of target preventing those firearm deaths. So as you can imagine, those kind of initiatives wouldn't be, means restriction is not very successful for a method such as hanging. So just, again, I think the surveillance system is able to have implications for suicide prevention and able to kind of show where tribal data may be sort of similar to U.S. data or different. We don't want to sort of assume it's always the same. The next slide. So here, this slide shifts a little bit. It's that same time period, again, from 2001 to 2006, and there's an American Journal of Public Health paper that sort of summarizes this data if anyone's interested. The first author of that paper is Mullaney, M-U-L-L-A-N-Y. I believe it came out in 2009, if I'm remembering the year right. And so these two charts look at suicide deaths and suicide attempts. And so what you can kind of see here is that the smaller chart, which is kind of towards the top, is looking at suicide death rates, and it's looking at differences between different ages and the two genders. And so what you can kind of see here is that there's a big sort of spike for the young adolescent or young adult males, that 20 to 24-year-old age range. During that time period, those were the folks that were most likely to be dying from suicide. And again, we know that youth suicide is a significant problem across all of the U.S., but if you were to kind of look at a chart like this for the general U.S., you would see spikes more likely to be occurring among maybe middle-aged or elderly men. And you can see that that's different here, that when you kind of start getting into middle-age and older, so Apache elders, there's very little suicide deaths, so it's very protective. So again, I was able to kind of see unique differences, and also this data also informed their prevention and intervention efforts that Novalene talked about, so really focusing kind of on this young age range. And you can see here that the female line is a little bit more flat, which is, of course, similar to U.S. data. It's usually more often males that are dying than females. That's a similar trend. But then if you go to the larger figure kind of at the bottom, that's actually looking at suicide attempts. And so one thing that will strike you, the difference between the two figures is that the lines are closer together. So here the male pattern and the female pattern is more similar. And you can see here that the highest rate or the spike is among a younger age group. So you can see the 15 to 19-year-olds is where we're seeing the most suicide attempts, both equally among boys and girls. It's still pretty high in the young adult age range, and then it starts to go down in sort of middle and later life. And so this data is also different than what we have been during this time frame than what we were seeing in the general U.S., where most of you are probably familiar. It's usually females are making more attempts, even though males are the ones that are more likely to die. And so this was something that we saw a little bit different. So again, this informed the age range that we were targeting with our intervention and prevention efforts, as well as kind of differences that we were thinking about for males and females and how to target those groups. Next slide, please. So again, this slide really basically sort of summarizes what I've just talked about. Some other new information that's on the slide that I haven't covered yet is one of the things that the surveillance system allows is when Rosemarie and Novalene and others on our staff sort of go out to fill out that second form that was pink in color, and they do that in-person interview. They're really able to talk to the individual about the reasons for their suicide attempt if they remember and want to share them and try to understand that. And so you can kind of see here at the bottom of the slide that a lot of the reasons that folks were talking about were relationship oriented. So they were having sort of a fight or a conflict with their boyfriend or girlfriend or a family member. They talked about the death or loss of loved ones as reasons for their suicide attempts, and sometimes that was another suicide, or sometimes it was maybe from a car accident or some other kind of death. In addition, the form allowed us to gather information that a lot of folks were using alcohol or drugs at the time of their suicide attempt. So that was something that was becoming of concern for the tribe. Next slide, please. One thing that I think is, you guys may have more questions about this kind of at the end of our presentation, but one thing about the surveillance system is it gathers this wonderful kind of quantitative data, and our staff try to get to hear the stories of everyone that they meet and that they connect to services. So what we then do is we sort of, the Hopkins Technical Assistance team helps to kind of put all the data together, all the numbers, and kind of then present it back to our Apache colleagues and our key stakeholders in the community, and then sort of get their reactions and interpretations of the data and trying to then understand how it makes sense. And so here we just have one example of this, which I think is nice to try to look at. And so here you can see some of our stakeholders' sort of interpretations of the findings. And so there you can see one of the things we were curious about is trying to understand sort of why hanging was so prevalent as a method for suicide death, despite sort of having rifles and those kinds of firearms available on the reservation. And so you can see here some of the reasons that the community thought that could be, including that it's a sort of a silent method and there's sort of no disfiguration. So the community has some awake sort of ceremonies when a person dies from suicide, and the idea might be that way you wouldn't be sort of disfigured for those ceremonies. So then there's some others there about sort of the gender differences, about sort of the males losing their role in the culture and not having as many of the traditional ceremonies, and that might be why that young males are having more deaths. Here you can also see some of the influences about the loss of culture and the influence of media. Another one that's interesting that you guys may want to sort of ask Novalene and Rosemarie a little bit about too is sort of the youth are having a hard time maybe talking about or identifying their feelings or some of the problems in their life, and so that's sort of reflected here in this this expression, youth feeling somehow. But if you ask them how they feel, or if they feel mad or angry or sad, you may not get sort of a typical response. So they might say they don't know, or somehow is kind of an answer. So these are just some of the sort of the other more qualitative community knowledge that we sort of synthesize together with the hard numbers that the surveillance system gives us, which I think helps to create a nice, a better, more well-rounded picture of what might be happening in the community. Next slide, please. So to try to summarize for you guys sort of the outcomes or the successes of this program is what we really, and again, the surveillance system program, like Novalene and Rose have sort of summarized for you guys, it's, there's this initial mandated reporting, this yellow form that kind of comes in that helps us, the staff then go and reach out to those at-risk folks in the community, get more information, sort of refine our data, but also connect them to services. Has been going on for a long time now. So we can think of it as a comprehensive program, not just as sort of a data gathering mechanism. And one of the things that we're seeing over time is there appears to be what we're interpreting as an increase in awareness in the community about reporting, about suicide prevention, about identifying those at risk. So over time, what we've seen is that the number of reports that have come into the surveillance system has increased over time, and so we don't necessarily interpret that as that there's necessarily an increase in suicidal behavior over time. We think it's that more people are coming forward and making reports. There could be somewhat of an increase, but we don't think it's all attributed to that. That there's maybe less stigma, more people know about this system. I mean, we had in the beginning, Novalene and Rose might reflect on this later, it was much more sort of the professionals that were making the reports, so maybe through the ER or through the counselors at the local community mental health center, and now it's much more becoming more widespread in the community where family members might call in about other family members, or friends call about friends. Sometimes we even have people call about themselves. And so we sort of see that as the success of the system. Our staff have also gotten really good at trying to connect with these at-risk folks in the community and becoming more successful at finding them. Sometimes it can be hard because some of the at-risk folks in the community may move around a lot, or sort of live in kind of different places, or not be hard to find sort of during normal working hours. And so our staff have gotten really skilled at that, and they're able to follow up. I think I would say at least 80%. Novalene can correct me later when she kind of gets on for the question and answer. It might even be up to 90% in some cases that they're able to find and follow up with. And we've also seen through the data an increase in folks seeking treatment after their referral. So when they come in through the surveillance system, sometimes they've already had a referral, like if they came into the ER or other things. But no matter what, our staff go ahead and make a referral as soon as they get the form to the local community mental health center. But then we try to gather some data if they actually then go and follow up with that appointment. And we have seen an increase in that over time. And so we think that that's an outcome of our staff really trying to talk to them about the importance of getting help and helping them problem solve any barriers they might have to getting help, whether it's transportation or filling out the intake paperwork. Our staff really do a wonderful job of that. And so again, I think these are all really sort of positive outcomes of the surveillance system, in addition to the data. Next slide, please. I think that we have a couple of slides here, or I might just do this one, but at the end, sort of summarizing what we think were our whole team, what we thought were some of the keys to success for having this surveillance system really be long-standing and well accepted in the community. And these are things you may want to ask, more questions about during the question and answer period. I think they're really important and interesting. And so I think that, the big one is that this community was really ready. This wasn't sort of, people sometimes ask us, is this kind of a Hopkins initiative or kind of bringing this data or this surveillance system? And it really was not. This initiative came from the leaders and key stakeholders and people that were passionate about this issue in the community. And so I'd say we're really sort of ready to tackle it. And so I think that was one of the keys to its success. And I think you can see there some of their implications and significance of the system. The other thing that I think that's really been important about this system is you can see there we use the initial CBPR, and I haven't probably wrote that out previously. So it's community-based participatory research. And so that really has shaped the data collection and how you could hopefully see a little bit how we interpret the data and the numbers, and also then the interventions that Novalene summarized. And so what that really means is we've actually had numerous versions of kind of the form. So I think, the sort of the technical team has sort of suggests kind of questions that you may want to ask at-risk individuals based on the literature and just what we know from good clinical practice with suicidal folks. But then we take that form to the community, and the tribal leaders, the tribal council might then say, we really want to know about this. We think maybe, religion might be important, or going to church, and maybe you should ask about that on the form. And they really give us a lot of feedback about how to sort of change or add variables over time that everybody wants to look at. And so I think that's really helped the system to be really successful. And also sort of we do, Novalene and all the staff do a lot of reporting back to the community about the data. So there are quarterly reports produced and trying to kind of go and do at least annual presentations to different groups about what the data is looking like and some of the different trends and getting feedback. And so I think that process has really helped the system. And the other thing that I think has really been important as we've had this wonderful, folks sort of leading the system on the ground. And so people from the community health workers like Novalene and Rose, you don't always have to have sort of the professionals in the community. That's sort of what we might think of as the traditional professionals, the counselors or the ED staff being the ones kind of doing the reporting or the number crunching or the connecting the services. It's actually, we've found it a lot more meaningful to have very skilled people from the community that speak the language, know the culture, know the norms, are passionate about this issue because it's affecting their community members and their family as the ones who are really leading the system. And so we think that's a really important ingredient to success. And then Novalene and the staff really work hard to communicate and collaborate with all the other, as best they can, and as much as their time allows, all the agencies and groups and on the reservation. I think that, again, is something that's been really important. So next slide, please. Great. So I guess at that point, we might be ready to shift for question and answer. I don't know if that sounds right, Michelle?
That sounds right to me.
Cool.
I think Nikki is our operator.
Yes, and thank you. And we will now begin the question and answer session. If you would like to ask a question, please press *1 and record your first and last name clearly when prompted. Your name is required to introduce your question. To withdraw your question, you may press *2. Once again, if you would like to ask a question, please press *1. One moment, please, for our first question. We have our first question from Shirley Swenson. Your line is open.
Hi, guys. This was really a good presentation, so thank you for that. It gave me a lot of knowledge I didn't have. But anyway, my question is, you utilized your elders enough, to go out to the community for awareness, collecting information, et cetera. Were these paid positions?
Yes, they were paid positions through the grant that the Tribal Police Department received.
Okay, thank you.
You're welcome.
There are no further questions at this time.
This is Michelle. I'm the project officer for this particular grant, and so I have a little bit of inside knowledge. And Shirley's question about elders, I think, is a really good one. And I wondered if you wanted to talk a little bit about the elders curriculum that you're working on now.
Sure, I can do that. So we put together an elders council in 2007 to start working with our elders on suicide prevention and having a little bit more insight and guidance from them so that we could work on suicide and feel comfortable doing it. And so through the efforts that the staff have had in working with our elders kept sharing with us that they wanted us to put together a curriculum that they could teach in the community to the youth and to family members to let them know that, to share some of their wisdom with them. And so we worked with our colleagues from Baltimore to put together our Elders Council, and then we've applied for funding so that we could put together a curriculum. So we're in the process of putting the curriculum together with our elders, so we've been having regular Elders Council meetings, meeting with them for a couple of hours and trying to figure out what makes the most sense for each month to teach one lesson. And so the elders have come up with the main theme for each month, the main topic, what are the key components of that lesson that they're going to teach, and then what they also want to keep in each lesson is respect and the Apache language. And so just covering that with our elders has been very insightful, and we've learned a lot from them during the duration of us working on the curriculum. They're doing quite a bit of storytelling and sharing with us what makes the most sense, monthly responsibilities that individuals should have, each month what the individuals need to know specifically in order to, have stronger life skills, improve their lifestyles, and, overall have positive outcomes. And so just looking at that with our elders and working on the curriculum has been really good for us as a staff. It gives us something else to focus on when we start to struggle with some of the follow-up visits that we're doing and, trying to help community members. And so working with our elders helps to inspire and motivate the staff to continue to do the work that we're doing.
That's awesome, and I'm really excited, to follow this particular thread in your project. And I wonder if you can say a little bit about how that fits in, like where the curriculum fits into your program overall.
So the curriculum that we're working on with our elders will be implemented in the schools, the community meetings. A lot of the curriculum that we worked on, we worked with our colleagues from Baltimore on revamping a lot of the existing curriculum that have been done in Native communities, and so just going in there and making it culturally appropriate, specific to our area. And we have our elders currently going into the schools, talking to the kids, so they go to the Apache classes that we have. And in the Apache class, we'll have an elder come for a day and talk to the students, and they share quite a bit with them. And so we just wanted something a little bit more structured, what the elders were describing. So they're saying that, when they're teaching the students, they wanted it to be consistent. And so in order for us to have that consistency, we needed to design a curriculum. And now that we're working on the curriculum and going in, hoping to take that into the schools and community meetings, we're hoping to also take that to PAC meetings so that we're not just teaching the youth, the elders aren't just teaching the youth, but they're also going to be able to talk to family members and guardians and, you know, be able to share a lot of this information with them. And so it fits right into a lot of the work that we're currently doing. The only thing that we don't have is the finalized version of the curriculum, but it allows our elders to actually give back to the community. And that's what the elders really talk about, is how important it is for them to give back the wisdom and the knowledge that they have. It's important for them to share that with the younger generation. What was given to them, they need to be able to give on to the younger, pass on to the younger generation, and they feel that if they don't, then they haven't done the tribe any justice by taking that with them if they were to pass on with all of that information. And so they're really open about sharing a lot of things with us, and they also do a lot of teachings. We have elders teach the youth how to do sewing, some of the crafts, and so our elders are just a strong giving group, and I think that's what inspires the staff even more to continue to do the work that we're doing. So this coming April will be 7 years that we've been working with our Elders Council. We have over 50 members that participate in our meeting every month. And the only time that we compensate our elders is when they're actually going into the schools and talking to the kids and spending time with the youth, and that's when we'll compensate them for their time by giving them a gift card so that they can go and, you know, buy a little bit of stuff, and in return, you know, just thanking them for everything that they're helping us with.
Thank you. Thank you.
You're welcome.
So, Nakia, I want to check in with you and see if we have any new questions for our group.
Yes, we do. Our next question comes from Bill Connor. Your line is open.
Yes, thank you for taking questions, and thank you for the presentation. It's very helpful. If I understood correctly, you're using the community health workers are the people doing the follow-ups, and I was wondering what kind of how you recruit or select them, and how you train them, and how you support them in the work that they do, and particularly the follow-up work. Thank you.
So the staff that are currently employed with Johns Hopkins applied for the positions that were posted specifically for the Celebrating Life program. And when we conduct our interviews, we ask a series of questions specifically to what we're working on in order for the individuals to understand exactly what they're going to be doing in the community. So we do a lot of one-on-one with our follow-up visits, and then also sometimes we do group presentations. We present at conferences, and just the staff having that understanding and, you know, understanding their level of skill set as well. And then we meet with our colleagues from Baltimore to do a lot of our training on what needs to happen specifically for the grants that we receive funding for, to make sure that we're meeting the goals and the objectives, and that the staff are fully qualified to be able to implement and provide the curriculum that we've received training on. And so we do week-long training, sometimes here in Arizona or in Baltimore, where we're covering specific curricula that needs to be taught by our staff. And for the surveillance system itself, we provide a lot of the training here in the field. So we do where a staff member does quite a bit of observations. We do a lot of role-playing, and we also go out in the field with them and observe them actually doing the follow-up visits. Some staff that have applied found out later on that this is not something that they can do, that it's really hard for them to actually ask individuals about suicide, and, you know, that's not something that they want to be focused on. They want to focus on more positive things, and so it weeds it out itself, because you have to be mentally strong, emotionally strong in order for you to work on a program like this. That day, you know, pretty much every day, this is what you're doing, and the staff members that we have, we're fortunate to have a strong group of individuals. Excuse me. Oh, excuse me. We're fortunate to have a strong group of individuals that work for the Celebrating Life program and have been for quite some time in implementing and doing the follow-up visits for the surveillance system, where since we don't have a high turnover rate, our training is just more like refreshers where we're going through and doing reminders of what we need to refresh ourselves on. We also ask for training from Baltimore, which before we avoided, which is funny. As we've grown into our positions a little bit more, sometimes the staff will ask if, I think we need to do a refresher on professional boundaries. I think we need to do a training on this, or we need to do a training on that. And so we'll send our colleagues in Baltimore an email letting them know, okay, so this is what we would like to receive additional training on, and they love it because this is what they want. And so the relationship that we have with our colleagues from Baltimore is very unique. We have a strong relationship with them. We work very closely with them, and we talk with them on a regular basis. Over the phone, we do a lot of Skyping, and that's how we do a lot of our trainings, too. And sometimes we'll do trainings with them over the phone as well, and I think that a lot of people seem to be concerned about the distance between the two offices, but we don't seem to fill that gap because we've been able to build a strong relationship with them. We ask for help when we need it. We know that they're there to support us and guide us, and whenever we struggle with things, they're always there to help guide us. And, we feel that a lot of the training that we've received is from them, and it's allowed our program to grow and become really strong. And our elders also provide guidance in that sense, where if they feel that there's something that wasn't covered for us, then we try to take care of that as well. We also do self-care activities with the staff, and I think the self-care activity that we love the most is when we get to spend time with our elders and go to the meetings and go to the schools, and that, for us, that's really good because it re-inspires us to go back out and do better. So the training that we receive is very unique, and it's different. It's not something that, you would see in a regular program because it's specific to the surveillance system. So I hope I answered your questions.
Thank you very much.
Our next question comes from Debbie. Your line is open.
Afternoon. One of my colleagues had a question, and it was, can the Apache Nation, can you guys send us your elderly curriculum, because we might be wanting to implement that with our elder group too?
So we are not done with our elders curriculum. We're still in the process of actually filling in all of the blanks. We have a format of what we're doing. So far we've gotten through June of exactly what themes, like what's the main topic, what they want us to put in the actual curriculum, and now it's us writing, our colleague in Baltimore putting it together, and then us going back to the Elders Council and them finalizing it. So we're a while, it's going to be a while before we are even done with the curriculum, so we're not quite done with it. We have an idea of what it's supposed to look like, but we're not there yet, unfortunately.
Okay, well, maybe a little the beginning of it, so we might be able to get started on ours too. And thank you.
Yeah, we can work with Mary on putting together something that would give you an idea of what our curriculum might look like.
Okay, thank you.
You're welcome.
There are no further questions at this time.
This is Michelle, and I would just to piggyback on what Novalene just said, you might also think about looking at the American Indian Life Skills just as a place to start if you haven't seen it, just to see, because that was originally a Zuni curriculum, and then it was adapted to be more generalizable. And you might think about what kind of topics would be covered and what sorts of things would be applicable to your tribe. And then and kind of see like how you would put something like that together. And it sounds like the way that they've structured it is it sounds like it's 12 sections because it's month by month, which is one way to do it. So I just wanted to offer that also as a potential resource for you if you're thinking about putting together a curriculum that looks at conveying values and things like that from elders to youth. So it sounds like, Nikia, we don't have any additional questions from our audience today.
Yes, there are no further questions at this time.
Okay. Well, I want to thank everybody for being on the call today. I appreciate you joining us for this great discussion. Your questions were outstanding, and I want to thank our presenters for their time today to share their accomplishments of their grant. We have a lot to learn from them. I can speak on behalf of SAMHSA in this regard. We watch them very closely because we're learning quite a bit from them. So I really appreciate you all being on the call today. And this will be recorded, so we will be posting it to the SPRC website, sprc.org, and it's under SAMHSA webinars. So if your colleagues missed it, or if you want to go back through and re-listen to some of the content, then you'll have the opportunity to do so. Thank you so much, and we'll see you again very soon. Thanks, everybody.
Thank
you. This now concludes today's conference. All lines may disconnect at this time.